Well, hello, everybody, and welcome to ASDEN TV. So this year, we're going to start off ASDEN TV by holding a roundtable to talk about topics of interest, topics that we all, as clinicians and as interventional nephrologists, are concerned about, and also which furthers the mission of ASDIN, which is promoting excellence in dialysis vascular access care. My name is Catheter. I'm the interventional nephrologist and the chair of the communications committee and ASDEN counselor. And with me is a very, very eclectic and educated bunch who will bring in together their own experiences on topics, because today we're going to talk about all about catheters. Catheters. We love them, we hate them, but we definitely can't live without them. So heading off the roundtable today is going to be Danny Patel, all the way from a passenger lounge in the airport. So I thank you, Danny, for joining us from the passenger lounge. I'm not going to name the airline. So Danny, if you can just give us a little introduction about yourself and just a two-liner introduction, then we'll go to the next person on the panel.
Sure. As some of you may know, I'm an interventional nephrologist practicing in Daytona Beach. I practice private practice interventional nephrology, and kind of in practice for the last 11 years, 100% dialysis access practice.
Excellent. Aisha, all the way from New York. So Aisha Sheikh, who's a superstar, social media superstar, as I've always mentioned. So Aisha, if you can just give us a brief introduction, although you don't need any.
Thank you. It's so lovely to be part of this crew. And as Karthik said, I'm based in New York City, and I'm an associate professor at Memorial Sloan Kettering and Cornell. And my background is in interventional nephrology as well as onconephrology, and I'm absolutely delighted to be part of this group and really looking forward to this discussion today.
And definitely, last but not the least, the professor in the bunch, Adrian Sequeira, from all the way from LSU. And so Adrian, if you could give us a little brief introduction of yourself, that'll be wonderful.
Thank you, Karthik. A pleasure to be here with Danny and Aisha. My name is Adrian Sequeira. I graduated from LSU in Shreveport. I'm professor of medicine. I'm also the program director of Interventional Nephrology Fellowship. I've been in practice now for 12 years, and Karthik Ramani used to be my fellow. End of introduction.
Well, I love that introduction, Adrian, and I'm so blessed actually to be joined by such a wonderful panel. Now I'm going to ask Aisha to talk about another part of catheters, which is the most distressing for me. It's the infected catheter. I mean, how do you deal with these infections? And so, Aisha, if you can give us a little insight into that, that'll be wonderful.
Sounds good. I hope you all can see my slides. And so, the topic that I've been given is perhaps the most dreaded complication of a catheter. My goal today is not to describe exactly how to treat each and every scenario, but to kind of give a flavor of what, as clinicians and as patients, we should be looking out for and to prevent and treat this dreadful complication that is associated with catheters. So as you all know, that catheter-related bacteremia is something that we all dread in our dialysis units because of the poor outcomes that it's associated with. And the incidence can vary quite a bit, and everybody should know the incidence rate in their dialysis units, and I'll allude to that later on in the talk, but it can vary from 1 to 5.5 cases per 1,000 catheter days. It's a little difficult sometimes to understand whether it's 100 catheter days or 1,000 catheter days, but generally speaking, in the literature, the incidence is described as number of cases of bacteremia per 1,000 catheter days. And it's not just a source of problem for our patients in terms of morbidity and mortality. It's a costly problem. It can cost anywhere from $17,000 to $32,000 US per episode. And there's several risk factors, but the number one and the most important one is the longer you're going to have a catheter, the higher your risk of infection would be. So prolonged duration is certainly one of the highest, or perhaps the most weighted risk factor for catheter-related bacteremia. And then all these other things that I've listed there, the technique, the conditions under which we place a catheter. We just mentioned how often some catheters need to be exchanged, and each time you're exchanging a catheter, you're potentially introducing a risk for infection if the technique and conditions are not ideal. Skin and nasal colonization with bacteria, especially Staphylococcus, has been shown to be a risk factor. The central venous catheter hub colonization, and this is why the care of the hub is so important when we are accessing catheters. Thrombosis, fibrin sheath can harbor bacteria, so CVC thrombosis is a risk factor. And prior history of catheter-related bacteremia appears to be a risk factor for future episodes of bacteremia. And then, of course, immunocompromised status. But the most important one is the longer you have it, the higher your risk of infection would be. So when we are addressing catheter-associated infections, we really should look at it in this manner, where you're talking about prevention, which first and foremost is catheter avoidance. But as I'll show you, as much as we'd like that, we still use catheters in our practice quite a bit. So we, in that case, have to have universal precautions. That includes hand hygiene, masking, exit site care. And then, of course, education. What are we telling our patients about catheter care? And most importantly, dialysis staff needs to be educated as well, so they are aware what to do and what not to do in terms of taking care of these catheters and advising patients when they ask questions regarding catheter care. And then last but not the least is a treatment. So, when we are dealing with catheter-associated infections, whether it's exit site, tunnel infection, or bacteremia, as clinicians, we have to look at two things simultaneously. What antibiotics am I going to use, and what do I do with this catheter? And every single catheter-associated infection has to have management plan for antibiotics and management plan for the catheter. And the fact is that, as I mentioned, the longer you have the catheter, the risk of bacteremia increases. And this is a study that was published in 2013 in incident hemodialysis patients, which is patients who started with central venous catheters for dialysis. The risk of bacteremia associated with the catheter was 35% at 3 months, 54% at 6 months, and it rose to 79% at 12 months. So when I'm counseling my patients, my takeaway or take-home point for them is, look, the longer you have it, the chances are that it will get infected. And that's one of the ways to educate our patients. And patients can do a wonderful job of taking care of the catheter, but there are some risks that are embedded, no pun intended, in the catheter that predisposes them to infections. And no matter how much they try, some of these catheters can get infected due to no fault of the patient. And if you look at the proportion of catheters that are removed non-electively, meaning you're not wanting to remove it, but you have to, 50% of those, meaning half of those, are removed because of a catheter-related bacteremia. So this is a huge problem, and it results in removal and replacement of catheters half the time a catheter is removed non-electively. Now, as much as we want to avoid using it, the fact is staring at us right here in this slide. This is from the USRDS database. 80% of incident hemodialysis patients use a hemodialysis catheter or central venous catheter to initiate dialysis. And 19% of prevalent patients use a catheter for hemodialysis. So even when you lower the use of catheters among prevalent patients, 1 in 5 of our patients are still dependent on a catheter. So again, this is a big problem because, as I mentioned, the longer you have the catheter, the higher the risk of infection. And infection and catheter-associated infection comes in many different shapes, sizes, and forms. For instance, we can be talking about an exit site infection or a tunnel infection. We can be talking about a catheter-related bacteremia. And the worst of all, we can be talking about metastatic infections. This is a picture of a heart valve with endocarditis associated with a catheter-related bacteremia. You can get osteomyelitis. People can get epidural abscesses. So this can be a big problem if it becomes a bacteremia. So you should really try to treat the exit and tunnel infections aggressively so they don't become catheter-related bacteremia events. And the risk of sepsis, as you all know, with catheters is 2-fold to 5-fold higher than AV fistula or AV graft. So this is a complication that is common and will happen the longer the catheter stays in. And as I mentioned, when a patient presents with catheter-related bacteremia, every clinician has to think about the antibiotic management as well as the catheter management. When I see fellows, just tell me that their treatment for a catheter-related bacteremia is systemic IV antibiotics, and that's where the management stops. That is never the correct answer. And you either have to use systemic antibiotics plus a lock solution, or you have to use systemic antibiotics with catheter exchange, or you have to use a systemic antibiotics with catheter removal and placement of a new catheter, same place or somewhere else with an interval. But IV antibiotics alone is never the correct answer for management of catheter-related bacteremia. And the duration of antibiotics varies depending on the bug and on how sick the patient is. And is the patient's infection limited to bacteremia versus is it metastatic infection? So if you have MSSA, gram-negative bacteremia, you can treat it with systemic antibiotics and lock solution for 2 to 3 weeks. If it's MRSA, it's going to be longer treatment duration for 4 weeks. And if the patient's unstable or has metastatic infection, the antibiotic duration can go up to 6 to 8 weeks. So it's not a cookie cutter approach. You have to know what bug is causing it and what the patient's condition is, and if there is presence of any metastatic infections such as endocarditis. And then catheter management is always a little tricky because we like to preserve our venous access sites, and many a times our long-term catheter dependent patients are on their last access site. So catheter salvage is possible, especially if it's an MSSA gram-negative infection, but again, you can salvage it or try to salvage it with IV antibiotics plus a lock solution, not with IV antibiotics alone. My approach usually is catheter exchange. I like to remove the old catheter because any residual fibrin sheath that is, or endoluminal bacteria that is growing in that catheter, once it's out with catheter exchange, I feel a little better. But we've all had situations where we've had to remove the catheter altogether because the patient's too unstable. And that is a condition you should not try to preserve or salvage the catheter because that source of infection can kill the patient. So, and that typically would happen in Staph aureus infection. So one, as a clinician, one really needs to be aware of that. And then the most important point is when we send blood cultures on our patients when we suspect them to have bacteremia, I have seen this a few times where only gram-positive antibiotics, coverage antibiotics are started. And yes, you will be right 80% of the time, but 20% to 30% infections are due to gram-negative organisms. So when empiric antibiotics are started, you have to cover both gram-positive and gram-negative, and that includes both IV antibiotics as well as catheter lock solution. And then you can tailor it down depending on the culture results. This is what I was alluding to earlier. Everybody should know the catheter-related bloodstream infection rate in their facility. And if it is greater than 3 per 1,000 catheter days, then you got to look at your policies and your training and your staff and your education and your SOPs and what you can do to lower the infection rate in your unit. This is critical, and it does make a difference when you take a look at the practices in your center to lower the infection rate. The easiest and the best way to do it is to have fewer catheters, but some of us know that getting down to 0 number of catheters is just not possible sometimes given the patients that we have in our dialysis units. So just to recap, hemodialysis catheter-associated infections need to be addressed by prevention of infection, by using hand hygiene, masking, avoidance of catheters, education of staff and patients, and then of course, appropriate treatment that takes antibiotic antibiotics as well as the fate of the catheter into account. So with that, I will end my talk, and I'm sure there'll be plenty to discuss with the panel on this.
No, I mean, this is phenomenal, Aisha. I mean, I think that, CLABSI and catheter-related bacteremia needs a whole episode to be devoted towards it. It's so complex. But one thing which I think we should be cognizant of is, a few things we should be cognizant of is when you just place a catheter, don't forget about it. Catheter is not just about placement and removal like we just talked about, but it's about monitoring the period within, because it is a big, big drain economically, physically, emotionally, all the above. And so we're all affected by it. That's number one. Number two is catheter-related bacteremia is always not about the catheter or the antibiotic. It's not the bug or the drug sometimes, but it's about the patient. So incorporation of that life plan, just like Kay Doki suggested, is so critical, especially when you're talking about preservation of vascular access as well. So I think you did a phenomenal job in terms of incorporating all of that. And a lot of the time, especially in the hospital setting, which I'm in, I see a multidisciplinary approach. So it is not that you're the only person. Yes, you're on the front lines. You may be an end user. You may be the person who has a catheter, but involve your colleagues. Involve your infectious disease folks. Involve your friendly outpatient nephrologist. Involve them in that care. Involve the technician. Involve the nurse, because they're involved in the front lines. If it's a nursing home patient, they're changing their dressing. All of this is very, very critical. The kind of dressing to use, the preventive aspect. So I know that you've done a phenomenal job in incorporating all of that. So I'm going to start off by asking a question which my patient asked yesterday. So the question he or she asked me is, "Hey doc, I have had infections before. Should I take any prophylactic antibiotics for prevention and of catheter-related bacteremia?"
So that's a great question. So I'm going to, antibiotics, antimicrobials are slightly different terminologies, and I'll allude to both of those. So there are studies that have used prophylactic antibiotic lock solutions such as gentamicin, and to use it as a whole in the entire dialysis unit is not a good idea, because that's where the studies have shown where Staph aureus resistant to gentamicin has emerged. But you could tailor it to that individual patient after consulting with your ID. We have done this. We had an 88-year-old patient who was on his last access, repeated bacteremia, and we decided to do gentamicin locks on that patient, basically long-term as a prophylaxis after his bacteremia cleared, and we exchanged that catheter to a new one. So yes, on an individual level, you can do it, but not in a whole prevention dialysis unit setting.
Very true. Yes. Please go ahead.
So the one point I would like to make is there was so in terms of which lock solution can be used for prevention. So one is, of course, in such patients, you can use an antibiotic lock solution, but there are many antimicrobial lock solutions that do not have this tendency for antibiotic resistance, because you're not going to develop resistance to terolidine, or you're not going to develop resistance to a TPA. So, there was a pre-clot study that was published in NEJM some time ago that not only showed that the risk of thrombosis was less with TPA lock solutions once a week in 3-day a week hemodialysis patients, but they actually showed that the risk of infection was lower in that. And so in other dialysis units where TPA cost is not bundled, it's a little difficult, but I had the privilege of working at the VA where we were able to get TPA without any hassle, and we used to use it, and our catheter exchange rate was so low. Whereas when I used to work in interventional nephrology in private practice for 8 years, as you all said, out of 8 cases a day, 3 would be catheter exchanges routinely, and I don't know, there's no head-to-head other than that trial at NEJM. We haven't seen a head-to-head trial with this kind of comparison, but I will say cost is a big problem with that. So if you have a dialysis unit where I showed you the facility performance where your bacteremia rates are high, you should strongly consider once weekly TPA. And there was a study done by the Canadian group that did the math and said, you know, financially it's comparable, if not better, to do the TPA than to have more bacteremia cases. So I think that's one. And then, as we all know, there are other solutions that have been used. We were part of the Catheter study, you know, with the Neutralin, which is a combination of terolidine, heparin, and citrate. And it was at least in NKF, when they presented the result, it was a positive study where it did show decrease, I believe, decrease infection rate. I have not seen the published results yet, so I can't speak to that. So the point is, you can tailor TPA or lock solutions. Now, another thing that's been asked is mupirocin, right? And like prophylactic ointments. And the issue is, though it's not documented, the fear has always been mupirocin resistance developing. So most of us don't use it. And then the other issue is sometimes you can use mupirocin, but for nasal colonization, but people get recolonized. So then do you need treatment? So it's not become part of routine practice for hemodialysis catheter dependent patients, which is unlike PD patients where we all use local antibiotic ointments for exit site.
Excellent. No, I thank you for that. I think that the other question which I want to ask, and I'll open up to the panel as well, is about what specific instructions do you give your patients immediately after you place the catheter? Do you tell them, hey, you know, put a bag on it, have a shower, use a hand shower, you know, jump in a pool, you know, come over to Lake Michigan? What do you guys say? I mean, so I would love to hear about what all you do in terms of not only prevention, but in terms of instructions that you actually physically provide to the patient.
So I can tell you what I do, and I'm sure there'll be variability on this because there's no gold standard answer. But for me, it's pretty significant where if the catheter exit site hasn't healed and the catheter is not well embedded, and it can vary. In some patients, it takes a while for it to get well embedded versus in some it's quicker. I shy away from giving instructions that you can go bathe and shower. I know there's a lot of variability on this. I've had a lot of folks say, no, we allow them. It's a major lifestyle issue, but I'm a little conservative on that. And I really don't have any strong data to back my belief on this, but I'd love to hear the other folks practice on this.
Yeah, so I think, so I think for me, I mean, we still instruct them not to stand under the shower with this thing, even when they're sealed. I question that sometimes though. You know, a PD catheter, 2 cups, okay, shower away. Hemo catheter, 1 cup, don't do it. And I don't quite understand why. There's been some pushback. Years ago, Sandy Altman down in Miami, interventional radiologist, had come up with some bags. He had a system, you know, to put it over, and patients kind of make their own homemade bags and so forth. And I even question, what if I had a tunnel catheter? Am I really gonna take a bath and this? No, you know, I want to take a shower. And I don't think there's any good studies and trials out there. I don't think any nephrologists routinely tell their patients to shower because we're all scared of it. We're all scared of that sepsis and that endocarditis and everything else. We're all scared. And we tell them to protect ourselves partially, don't shower, don't do it. But I don't know. And I don't think there's a lot of good data. Whatever data is out there that I've encountered is not been great. So I really question, you know, I think this is something that needs to be researched more because just lifestyle. You see the women and the men. I mean, they're going through misery, washing their hair and this and that. I mean, you know, so I really wonder, you know, what should we be doing? I think in practice, we all tell them not to. We all tell them to take a bath, keep it dry. Don't ever get this thing wet. But is that the right answer? Some cuts never grow in. Some patients will never grow in. The only thing keeping it in is that suture you're holding on for dear life. And so for those patients, it's different. You know, other ones who, like these stuck catheters, they're not going anywhere. You know, is that calcium, is that fibrin, whatever, locking that in, is that going to protect them from an infection? Some people sneeze and get infected. Some people never get infected and are rolling in the mud all day. I don't get it. And I think there's something that we need to study better.
So, Adrian, how do you manage catheter-related bacterium in terms of how do you decide on where to salvage or remove? Do you follow the same algorithm that Aisha does, or do you do something different?
I think everybody follows the same algorithm. I'd be very hesitant to follow, to go off the beaten path if something were to go wrong. But one practical point that I follow is I use point of care ultrasound. Just like you use point of care ultrasound to access the tunnel in case of a PD catheter to see if there's a source of infection. Many times you'll get these patients, they say there's discharge, but you don't see anything. Well, put the ultrasound on the catheter tunnel. If you see blackness around it, around the catheter, there is fluid or there is blood, and that means that catheter needs to come out. And so that's something that I use. I've been using it off late, and it's quite surprising what you will find sometimes. Other than that, I agree with everything Aisha said, everything Danny said. I always wonder the same thing, for PD catheters, once it's embedded, they can do whatever they want. And yet we are hesitant when it comes to a tunnel dialysis catheter. And I'm like Danny, I'm hesitant too, but I know patients are doing whatever they want. They're doing whatever they want.
No,
So I'll end it with that.
No, I think it's time for somebody to develop a double cuff hemodialysis catheter pass. Who knows?
You know how difficult it will be to get that out?
Yeah, catheters.
Talk about retaining one cuff. Now you're going to have two cuffs retained.
So do you monitor? How do you monitor differently? I mean, I'm intrigued to know in private practice, how do you monitor? Do you monitor the same way Aisha said? And Aisha, I mean, you were in private practice as well. Obviously, did you monitor your catheters once you place them, per 1,000 days? And is that what you would suggest our viewers to do as well?
Yeah, so the facilities do it for you. So it's
right.
Not like the access center does it separately, but like at the VA, we would have to submit our catheter bacteremia rates to the visit every month. Yeah, so it's sort of their version of Joint Commission. And if we were above that point or that mark, we would have to submit an action plan for it. So I'm sure I haven't been in the non-VA dialysis world for about 6 years, but even before that, the infection rates and bacteremia rates are very closely followed in these outpatient units.
I wanted to add just one thing. This is not related to what you just asked. That if you have somebody who's persistently bacteremic, you've taken the catheter out, you didn't find any source of metastatic infection, but yet the patient is bacteremic, you're given a holiday. Like Aisha mentioned, I put aldols and just locked it with vancomycin. Or let's say it's MRSA. I lock them with vancomycin and I give systemic vanc, or I switch to Dapto. Yeah. That's the other thing. You switch to Dapto, but you lock it with vanc, because I don't think you can do Dapto in the locks. And you must remember, locks, it's not easy when they're outpatient. Somebody has to formulate it and give it to you. That's additional cost that I don't think the government will take on its head. But I just wanted to add, when you're on the last catheter, lock, and give systemic antibiotics. So
one thing, Adrian, this is kind of, when I was in the non-VA world, it was nearly impossible to do the lock solution, and it was far easier to get the catheter exchange done. So that was the approach. But in the VA, where you have an inpatient pharmacy available for outpatient dialysis, because it's a hospital unit, we were able to do it very easily. And we were able to get the matching antibiotic for the lock solution, but that's where you need the pharmacy support. So you're right. Yes. It's difficult in the real world. When I used to go to, a dialysis unit in the middle of nowhere in Kansas, there is no way we can do lock solution therapy there. And that's where IV antibiotics and catheter exchange would happen sooner versus a setup where you have the ability to do cath locks.
So I think, to add to that, I know this is not an audience which does pediatric a lot, so but I see some pediatric patients as well. And so unfortunately, I had a 10-year-old, now 16, who got a transplant who had 35 catheter-related bacteremias during his dialysis days, and they kept resuturing. To add to Danny's point, that obviously the cuff didn't incorporate, so every 3 days the nurse would resuture, and he was having significant skin breakdown issues, so many things. So again, to reiterate, catheter-related bacteremia or CLABSI is the bane of catheters. Please don't just place a catheter and forget about it. Please use your local monitoring. Please use the resources available. Use a multidisciplinary approach. Use the algorithms that Dr. Sheikh alluded to, and use some basic common sense, because there are a lot of things which scientific evidence doesn't support whether it's in terms of showering and other things, but please use a commonsensical approach and please monitor for catheter bacteremia, because it is the bane of things. But I promise my ASDEN TV viewers that we will revisit this in a full episode later to talk about catheter bacteremia, because it deserves that recognition for us to prevent that.